I'll be speaking more generally on a pediatric perspective on the WHO fungal priority pathogens list. And as Adilia mentioned, my colleague, Dr. Velaphi, will then be talking in much more detail about one very important pathogen, Candida auris. Okay, I'll just make sure I can progress. So I just need to disclose that I did contribute to the WHO fungal priority pathogen list as a member of a commissioned group, the Australian-New Zealand Mycology Interest Group. But all of the following slides and this presentation represent my own personal views, and I'm not speaking on behalf of WHO or ANZMIG or any other organisation. So in this talk, I'm going to discuss the WHO priority pathogen list in terms of process, a little bit about the pathogens themselves, and then some thoughts about implications for pediatrics. So there's a background of priority pathogen lists with WHO, as many of you know. Some of you perhaps listening were very involved in some of the WHO priority pathogen lists, including the bacterial priority pathogen list. Subsequently, that was published in 2017, as I'll discuss, but subsequently there have been other priority pathogen initiatives apart from the fungal list, including the very recently released WHO pediatric drug optimization priority list. So I think there is a precedent, of both WHO prioritizing drugs, but also considering pediatrics. And there's an opportunity here that hopefully we'll have some time to discuss. So the WHO bacterial priority pathogen list was published in 2017. There's a very nice paper that describes it in very great detail by Professor Tacanelli and colleagues. And the focus of that pathogen list was on identifying, excuse me, antibiotic resistant bacteria. So in that list, 20 bacteria are listed, and they are all bacteria for which there is antibiotic resistance that is problematic in terms of treating people infected. So among that list, there was a critical group, and the critical group included both multi-drug resistant tuberculosis, but among conventional bacteria, 3 of those, so carbapenem resistant Acinetobacter baumannii, carbapenem resistant Pseudomonas aeruginosa, and carbapenem resistant Enterobacterales. So a kind of a theme there. Some years later, so launched in just a couple of months ago, the WHO has released a much shorter pediatric drug optimization priority list. And so this is in recognition, as we all know who are interested in child health, that the development of medicines for children lags unacceptably behind that of adults by nearly a decade in many cases, and more than that for some particular classes of drugs. And following a resolution at the 69th World Health Assembly, the WHO and partners increased their efforts to ensure that age-appropriate formulations were available for children, leading to this list, among other initiatives. So on the PARDO priority list, there are some antibiotics that you'll recognize. Some of them are relatively frequently used in many parts of the world. Cefidoracol, up until recently, and indeed even today, is not very widely used. But all of these drugs are important for treating resistant infections in children. So the amoxicillin clavulanic acid is perhaps the simplest, but we have issues with appropriate formulations and also pharmacokinetics for our youngest patients. Cefidoracol, very much the newest one among this list. It has efficacy against a wide range of pathogens that are in the WHO bacterial priority pathogen lists, including those carbapenem-resistant organisms, but we're still learning how to use that in children, and it's certainly not widely available, although there have been efforts to stimulate that, as many of you may know. So that leads me on to discussing the fungal priority pathogen list. And I want to just take you a little bit about how the process for this unfolded. So how do you come up with a prioritization of fungal pathogens? It's hard to choose between them. In some ways, it's like choosing a favorite child. But essentially, the WHO convened stakeholder groups, which were mycology experts, and selected pathogens to be prioritized. And they came up with a list of 19 pathogens that were suitable for prioritization based on a range of criteria and arrived at by expert consensus. And then there was a process of selection of the actual criteria as to how these pathogens would be prioritized. So the prioritization criteria selected are these: deaths, annual incidence, current global distribution, epidemiology, and then the trends in those epidemiologies over the last 10 years, the amount of inpatient care that was required for these, complications of infection and sequelae of infection, antifungal resistance, ability to prevent the infection, available access to diagnosis, and whether and to what degree evidence-based treatments exist. So once those prioritization criteria were agreed, then systematic reviews were undertaken for each of the 19 pathogens to review the evidence for all of those criteria. So what's the mortality rate? What are the trends in the last 10 years? Is there a readily available preventive therapy? Are there evidence-based treatments, for example? And then based on that, the levels were assigned. So, for example, for mortality, greater than 70% may be considered high, 30 to 70% may be considered moderate, less than 30% may be considered, low mortality, etc. Expert opinion was used to supplement that as well, because the systematic reviews, like all systematic reviews, weren't able to come up with conclusive answers in all cases. And then finally, for this bit, a large discrete choice analysis-based survey was conducted across all 6 WHO regions. So some of you may be unfamiliar with a discrete choice experiment or a discrete choice analysis, although I'm aware that some of you on this call may well have participated in this, so you will have firsthand experience. But here's an example that's completely different from a German publication surveying the public about preferences about in the COVID-19 context. So you can see that people would choose between situation and situation B with a number of factors to help influence that. So do we want to reopen schools in 4 weeks versus immediately? But do we want quarantine for persons above 70 years? No versus yes. And so using this analysis, people are able to systematically prioritize their preferences. So the discrete choice analysis was very important to inform the research and development needs for each of the pathogens, but it was felt that this needed to be balanced by, in terms of an equity context, by considering the broader implications in terms of epidemiology and public health. So a second exercise with a best-worst scaling survey for public health importance was conducted. And here's an example of a best-worst scaling, again, from a topic completely unrelated to fungal infection. So this is a best-worst scaling for your preference for an appointment with a medical specialist. So is the best thing waiting 1 month for an appointment? Doesn't sound like it to me. Or is the worst thing the consultant will not be as thorough, consultation will not be as thorough as you would like? And the outcome of this best-worst scaling exercise, which was the overall survey was conducted in over 300 individuals across the 6 WHO regions. The overall outcome was that the public health implications were considered very important by the majority of respondents. And so that influenced the final outcomes. And then finally, the WHO fungal priority pathogen list was published in late 2022. And so this is the list. It's divided into 3 groups: a critical group, a high importance group, and a medium importance group. And so as you can see here, the critical group contains 4 different pathogens: Cryptococcus neoformans complex, Candida auris, Aspergillus fumigatus, and Candida albicans. And there's a total of 19 fungal species or species complexes in all important. I think those of us would agree. Some are important globally, others are more important in geographically more restricted regions, but all significant in terms of burden of disease. And so what I want to do now, just in the sort of final moments of the talk before I open up for discussion, is to highlight some particular areas where I think the overall fungal priority pathogen list perhaps deserves some tweaking, or at least some interpretation and commentary from a pediatric perspective, where the implications for infants and children differs systematically from the broader public and from adults. And so I want to highlight first Candida albicans, but also the other so-called Candida species, including Candida tropicalis, Candida glabrata, and Candida auris. So these are clearly crucial pathogens for critically ill children and adults, including those undergoing chemotherapy for malignancy. But in pediatrics, there is a particular issue with invasive candidiasis and neonatal infections. And so I think there is more work to be done to be particularly considering effective therapy, diagnostics, and better surveillance for candidiasis among neonates. Next is to consider Aspergillus fumigatus, but really perhaps other molds, other filamentous fungi on top of that. And that is just to consider the issue in terms of our available treatments for these infections in children. So even in highly resourced settings, we have major issues treating and preventing these mold infections in children. For example, in children undergoing chemotherapy for malignancy, because often the sort of backbone drug that will be recommended in guidelines and used for adults will be azole antifungals, where there will be unacceptable drug-drug interactions in many settings that cause people to avoid that, and either have somewhat more difficult to administer intravenous therapy, for which there is often not quite as good an evidence base, with some exceptions, but also sometimes, in fact, miss out on preventive antifungals and sometimes subsequently get fungal infections. So I think there are pediatric specific issues with drug-drug interactions, but also lack of available formulations for molds such as Aspergillus fumigatus complex. And then Pneumocystis jirovecii. So again, this was in the medium group, so the lowest priority group among the fungal priority pathogen list. But as we all know, there is a particular issue with Pneumocystis jirovecii infections in children, in infants with HIV, or in infants with severe combined immune deficiency and other immune deficiencies. And so there are perhaps pediatric specific reasons to highlight and perhaps reconsider prioritization for these organisms for children. So challenges for children, to sum up and extend what I've said before, is that our epidemiology of fungal infections in children across the globe is more limited. So as Adilia mentioned, fungal infections have been somewhat neglected compared with bacterial infections for all people, including adults. But for children, I think that's even more the case. I think we have less information, less good information on epidemiology. We certainly have less good information on PK/PD, so pharmacokinetics, pharmacodynamics, and dosing. We have limited access to timely therapeutic drug monitoring, and for some of these drugs, that's very important to treat these pathogens. For many of the antifungal options for children, high quality evidence for efficacy is completely missing or very limited and extrapolated from adult clinical trials. Appropriate oral formulations that are palatable and available are limited and sometimes missing. And as I mentioned before, drug interactions can be problematic, especially for children undergoing therapy for leukemia. So, considering the antifungal pipeline, what's coming, that's not the focus of this talk, but we're probably all aware that there are new classes of drugs being made available, and those are at various levels. Isavuconazole is being used routinely in many places, and there is some emerging data on how to use that for children. There is investigation into these other agents at various levels, but for none of these we have routinely available information for children just yet, although Adilia and others will be able to tell us later about where things are up to, and certainly on the front line and that in the people interested in this pentafungal infections and broader community. But there's still some work to do. So the fungal priority pathogen guideline needs to help us consider this in terms of the fungal pipeline is probably going to be beneficial to adults first before we have the same type of information in children. So considering that 10-year lag that often happens, can we narrow that? And so, but perhaps should we not complain too much? So there's a saying that a rising tide lifts all boats. Perhaps these drugs being developed for adults will also benefit those of us working in child health. But I think we have to be on the front foot to ensure that happens and to ensure children don't get left behind. So I want to sort of provocatively ask the group, do we need a PADO priority list for fungal infections in children? And I won't answer that, but I'll be interested to hear what people think. And so finally, I just want to acknowledge that the fungal priority pathogen list groups and contributors, particularly Justin and those listed there that I worked with on our little bit of contribution, and my other colleagues in the Australian New Zealand Mycosis Interest Group, ANSMIG. I've put my email address there and my affiliations in case people want to contact me later, but I'd be very happy to discuss or take any questions now, and I'll stop sharing my screen too.
Thanks, Brendan, and very helpful to see, especially also the process of how this list has been developed. And obviously you touched on the point of lacking a lot of data on children, so that should give a call into action, I think. And I also think we as Penta can play a role in that. How would you see this list as, could that drive a kind of new PADO document? Could we would there be anything we could take up, make the WHO aware? Any ideas about that?
Well, I think so. So I think the importance of these priority pathogen lists are that the WHO and others have done some work, and there's been enough time passed since the original publication of the bacterial list that they've shown that it's important in terms of actual engagement with researchers, governments, and industry in terms of prioritization and drug development and further research. So I think if that's true for the bacterial pathogens list, we can also think that it may well be true for the fungal priority pathogens list. So we have an opportunity. This list is important in terms of driving research, driving innovation, and ultimately therapy. Now, we don't have enough time since the PADO for bacteria was published in children to know the impact on that. It was only published in March 2023 in the final meeting of that group. So when some people may have known about it was in December, I think. So there's not enough time passed, and I think we'll have to see what happens. but there have been groups like GuardP and things that have successfully used advocacy to drive research and availability of drugs like cefidoracol already. So yes, I think engaging with this list and putting a pediatric lens on it has the potential to actually raise the profile and drive that research, drive that innovation in pediatrics.
Fabian, you have also your hand raised.
Yes, hi everyone. Good talk, Brenda. I want to know if when the group do this list of priority pathogens, do you use geographic area as, because I am very worried about some fungal species in my country, like Fusarium, that is important pathogen in our children. And the other one that is Candida parapsilosis that is increasing in my country. And we are aware that Candida parapsilosis are becoming resistant to fluconazole in pediatric, and Candida parapsilosis is an important agent in pediatric too. They measure like a geographic distribution of this fungal when they do this list of pathogens.
Yes, so that was attempted as part of this systematic review process. And I can tell you it was incredibly difficult for some pathogens getting high quality data on current global distribution as well as trends over the past 10 years. But yes, that was explicitly included among the priority criteria. And what you will see if you look at the list again is that some of the organisms are really globally prevalent, like Candida albicans, but some organisms that have a more local distribution but are still very important were included. So, for example, Fusarium, Lamentaspora prolificans, Paracoccidioides. So those are not major pathogens in all global regions, but they're certainly major pathogens in some global regions and reach the threshold for inclusion.
Okay, thank you.
There is a comment in the chat, like Iriak Bonse. I hope that I have pronounced it well. Apologize if not. She said that I think that the WHO priority pathogen list should be domesticated in some countries, just like the WHO EDL.
That's very interesting. I don't quite understand what that means.
Iriak Bonse, do you want to unmute yourself and explain it to us?
Hi, evening. I'm from Nigeria, and on the release of the WHO priority pathogen list, I followed some comments on Twitter, and quite a number of persons were wondering why one pathogen or the other was not considered like critical or at least high priority. So I'm saying that this list is a global list, but in some countries where some pathogens are definitely like critical or high priority, then there should be some domestication of the list, to also guide work going on there. So that's just what I mean.
Yeah, thank you for explaining. I think you've raised a really important point there, is that the challenge when you do a global list is it doesn't necessarily represent the ranking of the pathogens in a local setting. So as you say, in Nigeria or in Australia, where I'm from, the critical pathogens may be somewhat different in order from the global list. And so, yes, I absolutely agree. Regions and countries need to consider the list in terms of their own local epidemiology and priority. That's true.
So as part of introduction or background, The Candida auris, I think most people know that it was first isolated in 2009 from an ear of a 70-year-old man in East Asia, and I think since the name auris. And some studies suggest possible it was present as early as 1996. It has subsequently been reported in more than 50 countries, and it is a budding yeast, but almost never produces a pseudohyphae or hyphae. And it is frequently misidentified as Candida humuloni or Candida formata or Rhodotorula glutens. In contrast to other Candida species, it grows well at temperatures of 40 to 42 degrees Celsius, and it can thrive between pH of 4 and to 13. And it can withstand cationic stress, hence it might not respond just to some disinfectants. It has an increased ability to persist on dry, inanimate surfaces. And hence, once it gets into the unit, it might become difficult to eliminate. It becomes a big challenge, as you will see in the subsequent slides based on our experiences. It can persist in biofilms for significant periods of time and can colonize and persist on plastic surfaces for more than 28 days. So if you look at the infection, then that can be caused by Candida auris. I think the common type is bloodstream infections. I think a recent paper showed that 94% of children with Candida infection is showing up in bloodstream infections. Of course, it can affect other sites like resulting meningitis, endocarditis, urinary tract infections, peritonitis, and skin abscesses. Now, talking to the South African situation and experience, I think there was this paper that was published in 2019 in Emerging Infectious Diseases. So what I would like you to focus on is to look at that red block in terms of the proportion of patients with Candida infections who have, that is due to auris. As you can see, that Candida auris accounts for 17% of the Candida species that were reported in this paper. And then next to that, you can see that total incidence risk is 12.5 per 100,000 hospital admissions. And then they compared the public and the private sector. And you can see in the private sector, that means looking at the hospital that are not public sector, more used by people with medical aids or who can find themselves in the South African situation, whereas the public sector is mainly the government hospital. And the hospital where I work is a government hospital. So you can see the Candida auris is much more common in the private hospital than the public sector. Now, I think this has been mentioned already, that Candida auris, and I think because of some of the challenges that one sees with Candida auris, it has been put under that group of a critical priority group with Candida albicans, which I think, to me, I would agree and support that based on our experience in our hospital. Looking again, the same paper that I've mentioned, looking at about 256 children, 12 of 16 case series that were reported were from neonatal intensive care units. So suggesting that this is a major problem when it comes to neonates. And about 33% of those neonates, looking at of those children, were neonates, and a large number of them were preterm. And the mortality from these 22 papers ranged from 0 to 80%. I think one meta-analysis gave a number of 39%, but I think in some papers they give a number of 75%. So there's a wide range, and I suppose it depends on the characteristics of patients who are infected by this organism. Now, if you look at the patients in the paper that came from South Africa, patients who had Candida auris versus those who had other Candida species, you can see in the Candida auris was seen more commonly in neonates as compared to the other age group, highlighting that this organism is a major problem when it comes to neonates. Now, this paper is, I think was mentioned by Adilia about from neo-orbs, where just reporting in from a number of countries, low middle income countries, looking at Candida species. Again, you can see the Candida auris, 14% of the Candida species were due to Candida auris, as you can see in that red circle. And again, a number of those patients, those babies in neo-orbs who had Candida species, quite a high proportion of them came from India and South Africa. Now, what about our local experience in our hospital? If you look at all positive cultures, as you can see at the bottom there, in each year, you can see that in 2018, 6.5% of patients who had a positive culture, looking at the isolates, those cultures were related to Candida species. And that number increased to up to 10.2% in 2020, and recently, last year, was up to 9.7%. So from 2018, then the number increased from 6.5% to about 10% in terms of the Candida species in our hospital. This slide shows the number of isolates every month. As you can see, before June 2019, we've never seen any Candida auris. Although, maybe let me correct myself, because I sort of reviewed all our positive cultures back up to 2014. We had one isolate of Candida auris in 2017. And I don't know what happened after that, because it disappeared. What we did in 2017, I wish I can remember so that we can do it now. Because as you can see, we are finished. This thing is sitting with us on a monthly basis. It's very difficult to eliminate. So if you don't have it, keep it at bay, because once you have it, it's very difficult to eliminate. It has actually taken over if you look at other Candida species. As you can see, that blue color at the bottom, if you look before June 2019 or May 2019, you can see the common Candida species that we had in our unit was Candida parapsilosis. But from May 2019, the Candida auris came in and has taken over since that time. So it is a major challenge for us. Now, if you look in terms of percentages from 2018, in 2018, we did not have a single Candida auris isolated in the positive cultures. So at the bottom, those numbers are total number of Candida species. As you can see, 2019, 24% Candida auris, is written the albicans. It's not showing the other colors. The 58% in 2020, 58% were Candida auris. 2021, 64%, and 2022 is 56%. So the majority of Candida species that are isolated in our patients are Candida auris. And these are the organisms isolated in blood or CSF. Now, as you can see, this is a map of South Africa. Gauteng is a province where our hospital is. And I think this study looked at a number of centers in the country, shown by those different colors. And you can see where it is blue, it says cold, it means the numbers were less. It's not necessarily the weather, it's just talking about the hotspots for the Candida infection. As you can see, Gauteng has been quite having a challenge in terms of having a Candida auris. Now, the question has been, what is the reason for the shift that we're moving or that we've had the Candida auris and is stuck with us? What has this come about? I think the number of papers that look at different things. One of the things is a climate change that when it survives in those temperatures, so for it continues to survive. The other one has been the use of prophylactic antifungal drugs, including fluconazole and echinocandins. And then the increased use of antifungal in healthcare settings generally and in agriculture areas, and this exerts a selection pressure, and the use of chlorhexidine baths. So for us, number 2 in these bullet points and number 4, yes, we have been using these before. So whether then that did make it worse for us because of that, we don't know. Now, what is the evidence for this? I think again, the same paper, if you look, as I've mentioned already, the Gauteng province as compared to other provinces, the odds of finding Candida auris are almost 4 times. But when they looked at the patients, the treatment 14 days before positive cultures, you could see the odds of picking Candida auris if a patient has previously been on antifungal drugs was the odds were 2.3 folds. And if you compare those who had isole or fluconazole or amphotericin or echinocandins, you can see the difference was seen more with echinocandins having been used previously, and also there's some trend in looking at the fluconazole. And of course, the other factor was those patients were mechanical ventilation, central venous catheter, previous antibiotics were more likely to have a Candida auris as compared to Candida species. I think similar papers that have looked at this in adults. I mean this paper is including all patients, is not necessarily neonates only. It includes the adults. And now, the other problem that I've mentioned already is that this Candida stays on the skin and it colonizes the skin more efficiently than it does with the gut, contrary to other species which seem to be commonly found more in the gut. And then once it gets into the environment, in surface of equipment and the hospital environment, it becomes difficult to eliminate. And then the common sites in terms of the colonization include the groin, axilla, and mucosal surfaces. And it forms the biofilm, which makes it difficult again to eliminate. So around that time of the outbreak, 2019, 2020, our microbiologist, Professor Govender and Nilesh Govender and the team did swabs in all patients who were in the unit at the time. So our unit, the number in terms of beds in the neonatal unit, we have about 185. But at the time when they did the swabs, we had 195. So as you can see, of those swabs that were done, overall, looking at the last column, overall 33% of patients who were swabbed were in the unit had positive positive culture or PCR. They use both PCR and culture, but I just wanted to focus on the last column. But where most of the patients were found to have this, to be colonized with the Candida auris, were in NICU. 83% of patients who were in NICU at that time were colonized with the Candida auris. In the high care, 30%. In the surgical unit, which has also got a combination of ICU and high care, 70%. And then the standard care units, what we call Ward 66 and Ward 40, 28 and 20%. So this includes all patients who are in the unit that we did not know whether they were colonized or not. They were all over. Of course, some of them were in the isolation unit because at this time we already had some patients we had a Candida auris. Now, looking at where the Candida is commonly found, as you can see on this graph, is that as you look at the patterns at the bottom shaded area, those are the anterior nares. So you seem to find it in high colony forming units are found in the nares, so that if we're doing skin swabs, then it's important to say, where are we doing the swabs? Compared to the top in the ear canal, you can see the colony forming units are much lower than the other side. So it becomes important that if we are doing swabbing and we're screening, we need to make sure that we swab the right areas if we want to pick up this organism. But again, once you swab the patient, it does not necessarily mean it's going to go away because you have swabbed. And even if you have swabbed and it was positive and it's negative, it does not necessarily mean it's not going to come back. So in this slide, this was done in adults where they swabbed different parts of the body, and they swabbed at different times, at 3 times. As you can see in the last pie graph, is that 63% of patients had this were positive in every time that the swabs were done. And what is also important that maybe we should need to look at moving forward is that if you look at the patients with a positive Candida auris in the skin versus those with Candida auris that is negative, the other organisms that are found when you have Candida auris that is negative in the skin are your Staph epidermidis, Staph hominis, and the fungi like Malassezia species. So it looks like those organisms, if you have those, they seem to be protective against Candida auris. And it's thought that they induce innate and adaptive host immune factors to eliminate skin pathogens. And the interleukin-17 and the LL37, they inhibit Candida auris growth and skin colonization. But once you also have that colonization, then with other organisms, Klebsiella pneumonia, Pseudomonas aeruginosa, that was found more commonly in the patient also had the Candida auris positive in their skin. So we had a mix of fungi as compared to the other side where there's homeostasis. So it becomes important that maybe moving forward, we need then to recolonize some of our patients with the more natural occurring organisms than with the bed bugs. Now, this comes from the paper again from NeoOrbs, looking at the different species and the susceptibility. And unfortunately, a number of patients were not tested, did not have a sensitivity reported. But of concern, you can see that quite a high proportion of patients have resistance of patients with Candida auris, had a Candida auris that was resistant against amphotericin, fluconazole even more. Micafungin, again, a large number of patients did not have a susceptibility reported against them. So then what is the treatment? I think the treatment that is recommended, I suppose maybe the people will move away from amphotericin, is that for neonates and infants less than 2 months, one should use amphotericin B, and then if there's no response, consider caspofungin or micafungin. And then of course for children more than 2 months, then micafungin is recommended. Some people are also suggesting that we should give prophylaxis in situation where this Candida auris is common for neonates less than 1,000 grams. Again, looking at the same paper from NeoOrbs, you can see Candida auris when it comes to use of the antifungals. That red is more micafungin. So the people are starting to use micafungin for Candida auris, but some patients were treated with amphotericin only, and those black dots are the deaths. So looking at the deaths, there doesn't seem to be different between these two groups, but of course, some of them were not tested in terms of the micafungin. So the main thing then is infection prevention and control. standard precautions, of course, contact precautions are very important, hand hygiene, isolating these patients, and cleaning the equipment and the environment. So our major concern in our hospital that these patients have got high mortality, 51%. And our impression is that it's worse on those who are diagnosed with this infection and while on the mechanical ventilation. And also our impression is that once they have that infection, they're also more likely to stay longer on the ventilator and have a chronic lung disease. And also major concern, we don't know long-term what happens to them. So we are in the process of doing a formal study where we can follow up these patients and see what finally happens to them. So we have tried what we could, but seems not to be successful. We've put these patients, isolated them, we've got their own separate ward. As we speak, I think today we've got about 8 of them. Of course, there are 8 of them because we keep them there for life until they are discharged from hospital. We have increased the concentration of sodium hypochlorite from 250 to 1,000 parts per million. So the outbreak, we failed to control it, is ongoing, and it has become a major, the common Candida species in the unit, and is associated with a high mortality, which is our major concern. Thanks for me to be able to get all these numbers. I thank the neonatal staff in our hospital who are looking after these sick, vulnerable babies with this infection. Our IPCNS and collecting the data on the alert organisms, including Candida auris, and their guidance on IPC interventions. And to our colleagues, microbiologists, who keep on guiding us on use of antifungal agents as we have these patients diagnosed. I thank you.
I think with still only having a few options to treat in neonates with antifungals, is it time to reconsider if we really need antifungal prophylaxis in neonates to spare our antifungals, but also to maybe shift back the Candida species epidemiology?
Well, the question in terms of prophylaxis, what should one use now?
Because if we should use it at all, yeah.
Yeah, no, I mean, retrospectively, if we knew that this was going to happen, I would have said we should not start, we should not have started. But at the time, we were dealing with Candida parapsilosis and Candida albicans as the common organisms. And again, the numbers were still high. So we were concerned, and also we're losing babies from that. Yeah. And then I think with the literature coming up at that time, that this might help. So we did use it for the babies who were less than 1,000 grams. So whether that induced the Candida auris to come, I think to me, yes, resistance is a major concern, but where does it come from? Where was it all this time? Was it hiding somewhere? And then we used prophylaxis and made it worse. Yes, retrospectively, yes, I think yes, and not to use prophylaxis would have been a good thing. But the question now, should we go use mercaptagin, or will we get another Candida coming up? So for now, we're not using any prophylaxis. We just take them as they come. What we often debate as a team is whether to, every time we have a patient who's positive, should we swab everyone in that cubicle so that we can isolate and stop the spread? That's a challenge.
Yeah. Okay, thanks.
Well, Fabian, if you want, and then I have a very quick question as well.
Go ahead. Yeah.
Yeah, I was just wondering. Oh, sorry, Fabian, go ahead.
Me?
Yeah.
Okay. Thank you so much for your lecture. I was shocked or because of the number of Candida auris that you found in my country. We had one case last week in a neonate, and it becomes a national notice in all the papers, in the news. One case in one neonate in Brazil, and we had an outbreak in Recife, in Brazil, and it was 50 cases, but all in adults, no one children, and so we have no experience with Candida auris. And what I want to ask is, when you did the surveillance culture, the swabs, where did you look for? It was in the ear, in the skin. Where did you look for? And how is the frequency? How many times a week or a day, every week, every month that you check for Candida auris? And for the treatment, do you use micafungin in neonates? Sorry, Laura, 3 questions.
Okay, so in terms of the swab, so when it was done as a survey, it was done at one go. So it was done over a day or two when the swabbing done, that gave us those numbers. So it was done as a part of a screening. But outside that, so what we used to do would then, we did not, so here for that part, every child or every baby who was in the unit was screened. But otherwise, on a regular basis, at the beginning, we only saw babies who were in the same cubicle when we picked up the one that was positive. But now that is endemic, we have stopped doing that unless we see an outbreak, a jump of the numbers that we have on the background, or where we have a cluster that in one area, there are many that are positive. There's only then that we swabbed. And then the areas that were swabbed, it was mainly the skin, which was the groin, the armpit, and the nasal, and the periumbilical. Regarding the use of micafungin, initially we did use micafungin, but subsequently we're using more amphotericin because we found that a number of them were sensitive to amphotericin. So we're driven by susceptibility. So in the unit, most of the patients are still susceptible to amphotericin. So, but once we get the susceptibility that they are resistant to amphotericin, then we change to micafungin.